Okay, I'll introduce the case to the audience. A 72-year-old male patient was admitted for the treatment of claudication in the left leg. He had received stent implantation at left superficial femoral artery 6 years ago, and low extremity CT angiography showed total occlusion of the previous left SFA stent. The ABI was 0.76 on right side and 0.64 on the left side, and he's a past smoker and had a history of coronary artery disease and diabetes and hypertension and hyperlipidemia.
Okay, I can still can't hear, but we're going to press ahead here. Okay. So if you can give me an LAO shot, we have a very difficult, challenging case in that we have a CTO, obviously of a native vessel, and in the middle of the vessel we have a totally occluded nitinol stent. So some of the challenges here that we're going to pursue here, first of all, if we can go back through the first angiogram, we had a moderate amount of tortuosity that we had to navigate on the right side, the right external iliac. I don't know if we can loop the first shot. It was expertly crossed with a glide wire. I think on the way out we're probably going to have to stent this, since I suspect the patient will have some disruption. Here you see the picture. This is a straight AP, and you can see some ectasia of the distal common iliac, and then a very straight up shot into the bifurcation. Let's go through the third shot now. Jump ahead to the third shot.
Fairly significant stenosis.
Excellent.
In the right
so here's our shot. Looking at the anatomy, we have actually a very favorable bifurcation, and then we'll just take what we've decided to move ahead with is an angle 7 French sheath, which is going to give us some good backup. We're now going to take an ipsilateral on the side to open up the PFA SFA bifurcation. On the CTA, I don't know if you had a chance to look at that. We actually have favorably, and thank God, a nipple that you can't see here in the straight AP, which goes very much to the importance of pre-procedure planning. So what we're going to do here is, if you can give me an LAO on the patient, please, like a 20 LAO. I'm going to take an angiogram. And we're going to identify this nipple here. Be careful. Yeah? A little puff. Puff. Okay, so we're going to take this angiogram. Go ahead.
Wait.
So this is actually some favorable anatomy. Puff, go ahead. And will allow us with the sheath and then some backup. I think backup in dealing with a long CTO is very, very important. Obviously, we want to get in the same plane that we are with that nitinol stent, and that's going to be key. If we get subintimal and we cannot get in the intraluminal plane of the nitinol stent, then we're going to have some problems. And more problematically, we may have to potentially, at a later date, bring this patient back for a popliteal retrograde stitch in order to move forward. So if we can go ahead and we're going to move ahead with several wires, but I think initially we'll start with a 4 French end-hole angle glide cath that allow us to basically direct our glide wire. And the glide wire I would select, I like your opinion on this, start with a 035 extra stiff angle glide wire, 280 that's long enough for us to get through all this. So do we have that on the back table, please? I'm going to keep on talking because for some reason, my mic is not on in my ear.
So I think this is a particularly challenging case because we don't know
let's go ahead
where
and get
that
that
stent
wire.
is, whether it's subintimal.
We have a torquer ready.
Which wire do you want?
A 035 glide wire, extra stiff angle.
In cases of long SFA,
what we'll do is we'll get into the vessel, and then we'll work in the straight AP. How does that sound to you? How does that sound to you?
Glide extra stiff.
여기 좀 가운데 좀 봐주세요.
Glide wire? I don't know if I ran out of batteries, guys.
I think that's actually a very good option here. A retrograde option, I think, would be an excellent option if you have trouble crossing here, and it could be
that extra
a retrograde popliteal stick. It could be a retrograde stick right into the stent, or even a distal SFA
Okay, hold wire there.
puncture as well.
Okay, we'll let that hold wire. We're going to bring this
you encounter the same
angled.
problems if you go retrograde and then you go antigrade in kinds of being subintimal.
All right, so what we're going to do now is bring this catheter. What I like doing here in this case is to really put your nose in it, if you will, and I would like, could you put up a mask to show me using bony landmarks where that's perfect. Great, stop right there. So if we look at the ischial tuberosity, and we sort of freeze that, we're going to be able to get a sense of where we need to move with the, okay, so freeze that, okay, very good, thank you very much. So, do we have a torquer that we can put on the back of this?
I think the main advantage of going retrograde, though, is that you end up in the same plane as the stent. So even if you're subintimal when you come proximal to the stent, you can pop back in and have a chance of success. The problem from coming from above is that if you get subintimal coming from above, you may not be in the same.
What I'd like to do is, if you have a syringe, we're going to just take a picture here to make sure that we are where we should be, and I believe we are based on this. And if you can, I'm going to hold some pressure here, and I want you to, with the wire, to advance the wire. So I'm actually buttressing the 4 French end-hole glide cath, and good, push, push, push. Go ahead, good, 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 good.
So Dr. Singh is going to do the
So let's stop there.
Technique.
Okay, let's go work in the straight AP now. So we're going to. This is going to be. This is not something that obviously when we start moving here and coming subintimal. If we can take a quick picture here, just to make sure where we are, through just a quick shot of floor, or just a floor shot. Give me an injection. Okay. So we are clearly. We're clearly in the subintimal space here. And what I want to do now is to get an assessment here of where we're going to try to collect mind's eye between where we are and where we need to be with regards to the stent. Now, is this an extra stiff glide or is this a soft glide? So here's a crucial part right here. We have to, if we're going to get through this, have to be within the confines of this stent here. And I believe this is a soft wire. Do we have an extra stiff angle?
Extra stiff.
Yeah, the moment of truth will be whether he comes into the middle of the stent or behind the stent. If he's behind it, it's going to be a long day.
Ready here.
Good. Yeah. So if this, see, this is where we don't want to go. You can see here in the straight AP that this wire is lined up on the outside of that stent. So give me the other wire, please.
Dr. Urasawa,
and usually what I like to do is get a good buckle on...
Which wire?
Yes.
Do you want?
I think
you don't have a extra stiff angled glide wire. Extra stiff angled glide wire?
It seems to be
Extra
going to
stiff.
the outside tent.
Glide angle.
As you said, the key support is how to get the true
So-
at the stented segment. So for that purpose,
Extra stiff angled glide wire. So I think what we're trying to illustrate here is the importance of having a full armamentarium of appropriate wires to help you literally deal with CTOs.
Stented segment.
So you would punch it right into the stent. Yeah. I think that's the...
If we don't...
I think that at this point we had better use the steep wire such as Astator or Serige.
Yeah.
The CTO dedicated the wire so we actively getting the intraluminal
Well,
because at this point the wire usually is subintimal space and then out of the stent.
That's the key point here.
Yeah.
Let's see if we can try this. Oh, you don't have a glide wire, so we'll do some J wire, just so it's extra stiff. And what sometimes we can do is we can advance our catheter here that is in the subintimal space. And, okay.
Doctor, can you hear me?
We hear you very well.
Yeah. In your practice, at this point, what do you do? In my practice, at this point, I usually use CTO dedicated stiff wire. So I usually try to perform to actively get in the intrastent.
So you tell me then.
What do you think about?
We were just having that discussion. I think a technique, almost like a reentry technique, to try and get from this false lumen to the same lumen as the stent would be a possibility with a curved catheter and a stiff wire. The other possibility, which I think everyone on the panel likes, would be to do a direct puncture of the stent and go retrograde.
Retrograde.
Yeah.
Through the stent.
Yeah. There's a point back here that once we get into a plane, it becomes very, very difficult to get out of it. And this is where I actually prefer, see, once we get in a plane here, we're alongside the stent. And there's no way, unless we buckle this wire here, and it follows the same angle here. So we need to try to come up at a different angle here to try to reintroduce this wire into a different plane. And here we go with the J, and hopefully this will allow us to get into a different plane that will... Go ahead.
We really have no idea whether that stent was true lumen or false lumen when it was implanted.
So we're using basically, again, the standard CTO technique and trying to get into a different plane here. This looks a little bit more favorable.
How often do you IVUS these things as you're crossing?
And my instincts here, what do you think? Do we should keep on pressing here?
We had better image,
so very good.
little image.
So let's take a look if we're...
lateral image.
Yeah, so this looks favorable. And let's come back on the other side. I just want to see on both sides.
That was a slick move.
That needs a congratulations.
I think we are in the stent. We are not alongside the stent. What do you think? Okay, now this is the crucial part. Once we've made the first challenge of getting within what we believe the lumen of the occluded stent, is now trying to get into. So let's go back in the picture and see the extent of the occlusion of the native vessel distal to the stent. Do we have an angiogram of that? Why don't we do an angiogram through the sheath?
Okay.
Okay. Mm-hmm. So ready?
That was an impressive move, I think. He was able to reorient into a different plane and gain access to the stent. It was really quite nice.
Very good. So we have about a centimeter distal to that end stent, the nitinol stent, and this is going to be the crucial point because I can tell you doing a reentry catheter alongside a nitinol stent becomes very problematic, in part because it's over a 14 wire. So let's see what good graces we have here and trying to re-enter this. Now, frankly, my wire of choice here is to re-enter this, and I'm looking at 21, and I'm looking at the marker here,
it may be in the true lumen at this point and may actually go right down.
Well, I don't know if I'm going to be that lucky. Well, give me a shot.
Shot. So
here's the big issue. We are clearly subintimal in the native vessel. And now, in the absence of a reentry device, we would like to, this is where a variety of wires becomes crucial in trying to reenter this. Now this is a J wire. I typically would not use a J wire, puff that, to try to reenter. And do we have an angled wire by chance? Any type of angled wire?
Okay.
Yeah, puff.
Which type of angled wire?
Well, any angled wire. I would prefer an angled extra-stiff glide wire, but we don't have one.
Yeah, we don't
what
have
other
that
wide glide wires do you
그냥
have?
트러블 글라이드 와이어 주시면 돼요. 이거 말고. J.
Anyone have a favorite wire here to re-enter, or any thoughts about which wire would be best?
Stiff angle glide wire here.
So could you give me an LAO here? What I'm going to try to do is...
and they do have it there. They have it right behind them. I saw it this morning.
Yeah, I think that would probably be my choice, would be a stiff angled thermo. Occasionally, some of the 014 wires can be helpful for
Got this
re-entry.
wire is ready.
Yeah. Okay.
Okay,
So
we
is
need
this
somebody to stop
extra-stiff?
injecting air bubbles into the
pull this wire.
arteries.
Yeah, Dr. Riyad.
You know,
In Japan, we cannot use a re-entry device in
Like
this
this?
situation. And only
So
we
one
can
put a
use
corker on
is
it?
all 14-inch wire, tape-out wires, like a Conquest Pro kind of thing. You know, in my country, we have tapered 40-gram guide wires. It's very strong.
The hope here is to
so
not
give me an LAO,
propagate
please.
dissection too far.
and then we're going to take a little quick angiogram.
Although I think if you
Angiogram?
advance the wire loop, it would probably pop back into the true lumen fairly easily.
So we're pointed definitely, at least the wire in this view. So we can work in this view here. And would you point that, bring that up for me, please? As a mask on the screen above.
Yeah, I agree. Those actually are pretty good wires for this type of a
Very
case.
good. Thank you very much. So what we're going to try to do is align our catheter with our wire. And having this challenge here, give me a little puff here.
So this outcome suggests that that stent was subintimal all along.
Maybe we can
And
go
so there was
a
probably
few
a
trays, or-
recanalization of a long occlusion subintimal and then spot stenting, and the stent was
So this
in the
becomes going to
subintimal
become
space. So when it reoccluded, that makes it very difficult to recanalize. He achieved the hardest part, which is getting into the stent from above, but now he has to achieve the second hard part of getting into the true lumen distally. I think if you're going to stent a subintimal recanalization, you need to stent the whole thing so you avoid this type of a problem, or at least stent the entry and the exit.
What would you like to try? Because for me, again, in my practice here at this point, I would have a very low threshold of pursuing a re-entry device, but that's not an option here. You know, as the longer we go here, we don't want to extend this too far. Only we are always going to stent this.
Do you have re-entry devices in
Re-entry has
Korea?
become very
Which
important.
device? Outback? Yeah.
This patient is very tortuous iliac artery, so I think maybe
So
some
what are our options? What would you like to do?
Yeah.
iliac bifurcation.
It looks like a pretty good vessel to re-enter, though. I think it would probably be successful, but you might have to
Or cross.
you might
See,
have to
we can keep
to
on going
dilate
here, but
the
we're going to get
proximal vessel
subintimal.
first.
This is all subintimal.
So Krishna is taking care not to propagate the
So
section
what
too
we
far.
could do,
You could probably advance that loop down and it would eventually re-enter, but it might not re-enter for quite a ways.
How far would you take this loop down when you see these images? Are you going that far, or you try to stop over here and try to go retrograde? What's your advice?
My approach would be to take a re-entry catheter at this point. I'd probably dilate the stent in the proximal vessel to allow it to be delivered more readily, and then I would use the outback to re-enter, right there. Because I don't think we want to extend the section down much further here.
Well, I do agree because the larger you make your dissection, the larger amount, the longer stent you're going to need. So you just make your lesion much longer.
Yes. So I guess the next question is then, if he is successful in achieving a true lumen distally, what do you do with this vessel now? You have a long occlusion, occluded stent. Just balloon angioplasty alone is going to have restenosis rates probably in excess of 80%.
What would you like to try here?
Based on the Japanese data from Dr. Aida and his colleagues.
Maybe I use.
So we're going to get an angiogram here, just to see where we are.
And after that, if there are some dissection in proximal area, I put the stent in proximal area.
Okay. All right.
I think drug-eluting balloon would be nice to have here, particularly for in-stent restenosis or occlusion.
Go.
I think if you're going to go down the road of having to re-enter and the difficulties he's having, I think you're obligated to stent the outflow.
So we have to try something different
inflow,
because all we're going to do here
choice. But
is extend this
ultimately, the answer I think is going to be a stent technology here. I think that the challenge of re-entry here is actually going to be mitigated because I think that stent will buttress the back end of the outback and get you pretty close, even though it's over an 014 wire. So I think that's probably the right way to go.
I think in terms of what I would do in the U.S. With what's available to me, which is the only drug-eluting technology is a silver stent. So I would probably either reline this with a Viabond or use a silver stent. But I haven't seen the distal runoff yet, so I don't really know what that looks like. So that would also dictate our options.
This is an issue
the
here.
Viabond gives good results, but you have to try to preserve that one collateral over there,
continuing the subinguinal space.
2 centimeters below the oval, because
Yeah.
otherwise you might into trouble when it's close.
Yeah, maybe there's a few more collaterals distally, I think, too, though, so we might be okay.
But why would you like to try
if we lose that collateral,
But
as
why
long
would
as
you
we
like
don't
to try
lose
next?
some of the ones in the distal part of that image.
Astato, sorry.
I'm sorry?
Astato, sorry. At this point, we usually use the CXI supported very steep CTO dedicated wire.
Okay, well, let's try that.
Okay.
The thing is, the CTO wire, obviously, when we come in the stent, we can try to bring the catheter back up and try another reentry plane, just like we did before, to see
Dr.
if this
Hong, can you hear us?
Yeah, I can hear you.
Okay, I think they are ready in the other room, so I think we're going to switch over to the other room.
Okay.
And then we'll come back to join you later. I think, have you considered using an outback catheter here to try and re-enter?
Yeah, actually, we're changing the wire to Astato.
Astato 30.
Astato 30 gram.
Okay.
So
well, we're going to switch to the other lab, and then we'll come back and rejoin you later to see your progress, okay?
Okay, thank you.
Okay.
6 side.
French or 6 French?
Rich, can you hear us?
Yes, I can hear you loud and clear,
Thank
John.
God.
Yes, and I'm here with Dr. Choi, and we have an interesting patient. Can we have somebody present this patient that we're working on?
This patient is 64 years old male, and he suffers from the intermittent claudication. And his ABI, ankle brachial index, is 0.71 on the right side. The left side is normal. So we got a peripheral angiography. So peripheral angiography showed the total occlusion of right common iliac artery. And can you see the? Okay. So his past history is hypertension, hyperlipidemia, smoking. And can you see the CT angio?
CT angiogram would be good.
Okay.
Yeah.
So, okay, start.
Yeah,
as you can see here, just the right common iliac artery proximal part is total occlusion. Okay.
So as a CTO of the right common iliac artery, there's a diffusely narrowed right external iliac artery, possibly underfilled or possibly diseased. There's a high femoral bifurcation on the left side, it looks like.
We're going
We
to try
had
to
a
take
great
this out.
example of the IMA collateral.
Yeah,
To the,
keep the wire there.
femoral too.
Yes.
Yeah.
So, Rich, you want to just talk to us a little bit about what you've done so far in your approach here?
Well, the team got access both to the left groin and the right groin, which is nice. And so we've gone, going through the right side, couldn't do much. All I managed to do is try to get subintimal. So decided we go contralateral. Now I've gotten the wire about 2-3 centimeters across the CTO with a glide wire. And so what we're going to do is we're going to go up with an Ansel contralateral catheter because we've made some progress. We may lose it, but we're going to try. I think that not the best curve, but we're going to try it. So we'll try to get that Ansel up and over. Took the sheath out on the left side. So I'm going up with a 6 French Ansel. At least if we can get partially there, then I think we can get across it the rest of the way. We've actually made some pretty good progress with it on the contralateral approach. Ipsilateral wasn't going to happen. Retrograded wasn't going to happen.
I have to say these are my absolute favorite cases. Iliac CTOs.
Oh, darn it. Okay, well.
Fun to do.
That's fine. We'll go back
high
up to the
success
Omni.
rate, durable results, patients feel great.
Yeah.
Really, they're a lot of fun to do.
Let's go up with that Omni
I think
then.
the data would suggest that if you can cross from above, you have a better chance of succeeding and staying intraluminal.
Yep.
So I think an approach from contralateral from above, I think, is a good idea. Although the challenge is always getting enough backup support to get the wire through.
I'm surprised that we've had as much backup support as we have because I didn't think we would. We actually had pretty good backup support, so I'm a little bit more optimistic. Otherwise, I was ready to go from the left brachial.
I like a Simmons 1 catheter. Just park it right in there, and a lot of times that'll give you enough support, and then a straight hydrophilic wire. Anyone else on the panel? Ravish,
Let that wire drift up a
like
little
this?
bit, please.
I agree that the chance of success is a lot higher with the contralateral integrate approach than the retrograde. You usually end up in the subintimal space, and then you're faced with using an outback or a pioneer to get in the true lumen, which is not a great option in the aorta. Something for support like a SOS2 or a RIM usually can help as well.
Yeah, similar type of a curve.
Yeah. And then a stiff angle glide wire, again, it seems to be the go-to wire for total occlusions. It works well. If that fails, then trying something else. But usually that's the one I try first.
This is the one situation where I like a straight terminal when I'm
Is it
crossing
correct?
occlusion from above.
Kinked?
Yeah, broken.
The Omni kinked?
Yeah, kinked.
Yeah, it is.
Yeah, sometimes we like
Is it broken or is
the
it?
IMA guide.
It's okay.
Sometimes can provide at least
I will
some
change
some
it to
support
new one.
without
Give us a
having
new
to
one,
bring
yeah.
a guide, catheter up as a
Take a
sheath
new one.
guide. Because as Rich is showing, the support is so poor to get the guide up and over, but
Yeah.
sometimes the guides, like coronary guides, IMA shorts are probably fine.
The other, I think, point about the reentry in a case like this is that there is a stump on the right side, it looks like, in the common iliac, so there would be the possibility of reentering into that very proximal common iliac artery, which would be better than having to reenter into the aorta. So
Yeah, that's for
Outback
sure.
or Pioneer, I think, would be an option here. Rich, what are you doing now?
We're just switching I screwed up the Omni. So we're going back up with the Omni. We'll go up and over, but the IMA catheter is another option. But
They say there's no
what?
No more catheter.
No more Omnis?
Yeah, no more.
What do you have here? A rim?
Use a smaller
Yeah,
angle
this
like
is
the
a
universal flush catheter.
Is this the same one?
Yeah, same.
Okay, well let's try.
Pull
Can we fix it?
into which you pull into your sheath as it makes
Is it
quite
unkinking?
a hard structure as to give you
Okay,
a lot of
we'll try to
support
fix
to
it.
get over.
Like a contra flush catheter?
With the universal flush catheter, which you from the left will pull into your sheath, so it makes an angle to the angle you want, and from there on you can use your guide wire as a drill to get through.
Can you freeze the shot where I was up and over so I see where I need to go?
그 전에 했던 거 좀 주세요.
Go a couple shots back.
그 전 거.
John, this particular
freeze it, put it upstairs. That's good.
Reconstitution of the external iliac.
Put it upstairs, please.
If the external was occluded, how far down would you
upstairs, please.
Still be okay with trying the case with endovascular means? How much of an external occlusion would you still deem as okay?
In terms of how long of an occlusion would I treat?
Yeah, what if it reconstitutes only in the mid-common femoral artery?
Okay,
you
upstairs.
I have treated these cases all the way down into the common femoral. Typically, what I would try and do is maybe
is that upstairs, please? Freeze it,
femoral,
dye, and put it
or
up.
just extend the stent just into the proximal common femoral, if possible. But
freeze it with the dye.
I think it's okay in a case like that to treat into the common femoral.
Perfect.
But I'll try not to stent the common femoral.
Right.
Keep advancing with the wire.
Exactly. And then usually you want to, if you have some place to get access with a sheath in the distal common femoral or even the proximal SFA, you want to be able to get in there somewhere. As long as you can do that, then you're fine, I think.
It is possible to treat a lesion like this contralateral, although it's a little bit more challenging, obviously, with the stent from the contralateral approach, but it is possible.
Still wanted to do that kinking.
You could avoid
trying to catch it on
having
something.
to stick that femoral when the CTO extends distally.
Right.
It's a little bit trickier, though.
Is this kink permanent or?
Well, the other thing that we have to think about is the narrowing of the external iliac artery on right sides may not be atherosclerosis, just a spasm or shrink after a stop of the blood flow. So,
I know.
Sometimes we experience using iris observation. External iliac artery size is just a 3 millimeter diameter. It's not possible. That means just a stop flow induced vascular spasm downstream. So you don't have to treat every segment. Just
I think that's a good point.
The segment is good.
That's a good point.
I think I'm okay here.
Over time.
I think I'm still high, don't you think?
Still high. Yeah.
Am I still high?
Yeah.
Rich, can you hear us?
Yeah.
Okay, we're just chatting away here while you're
That's
working.
fine. We're just I'm just trying to get this Omni where it's supposed to be. I think it's still too high. That's looking a little better. Okay.
Yeah, okay.
Okay, now let's try to get that Ansel up and over a little bit, if I can.
What's your wire there now, Rich?
I just have a glide wire, but maybe the idea of a stiff glide might be the way to go. See if we can cross it here. You got a torquer
sort
there?
Of a double-edged sword. This stiff wire often will prolapse the catheter out.
Yeah. But if I could get the wire where I had it before, I'm be happy with that.
Success where the stump is so short that taking a V18 wire
will
allow you to get better purchase.
Yeah, that's an idea.
And then you can take an 018 quick cross to support you up and over.
Exactly. Ooh. Yeah. What do you think, team? Should we try the V18 now from here?
V18?
Let's try. I think we got it up here. Let's try it.
What's your approach here, Dr. Urasawa? Your favorite wire for crossing the CTO and the iliac arteries?
I always use 014-inch wire.
I'm sorry, which wire?
014-inch.
014. Which one in particular?
CTO wires, miracle type wires. Because if you use 014-inch wire, it sometimes goes to subintimal or extravascular space. But 014-inch wire, the damage is minimal, right? You can check the wire root by iris, and then if the wire root was wrong, you can try using the same wires.
Okay, let's get that torquer up here.
I have to say, with the availability of reentry catheters in the U.S., I rarely spend too much time on this type of attempt. So if the wire goes easy, then fantastic. If it doesn't, then we can use a reentry catheter from below and finish the procedure fairly quickly. And if you do the procedure carefully, the risk of vessel rupture or perforation even when your subintimal is extremely low.
It's not a good angle, that Omni, I think. That's not a good angle either with the wire. It's a little better here.
Dr. John, which option you would like to prefer, both femoral approach or right femoral and left radial or brachio approach?
You know, my personal approach would be to use bilateral femoral access like was used here. But I think nowadays a radial access is a very good approach to cross from above. You avoid the risk of complications with brachial access.
You have a new Omni?
And
let's go up with that new Omni.
You can get good support to cross. So you could use radial access and right femoral access.
Dr. Hoijo?
Yes.
Yeah, we have the long multi-purpose 5 French, 150 or 180. So if you want to radial approach, you achieve the strong backup. So
yeah,
I
that's
think just the pushing wire is maybe.
Yeah, that's a good option too. Wire going okay, easy?
Solve this problem.
No, not yet.
Not yet, okay. Wire going?
Yeah.
Wire's going through? Okay.
Not that cross. I think it's
is it going?
No.
It's not fitting?
Not
oh, there it is, okay. Is this the right, it's going to not
Hey,
fit
Rich,
the sheet?
I think maybe we'll give you a little time to work here, and then we'll go back to the other lab and
That's fine.
Come rejoin you again in a little bit.
Yeah, we're having fun. We'll go to that other lab. That'd be good.
We'll see you in a little bit.
We'll do it. Thanks, John.
Yeah.
Okay, we'll see you. We're back. Can you hear us? Dr. Hong, Dr. Yu, are you able to hear us?
Yeah, I'm Dr. Yu. Can you hear me?
Yes, we hear you.
Yes, we failed getting the distal tournament with the 0.035 thermal wire, so we changed the steep CTO dedicated wire, Astator 30 gram, supported by thermogliding catheter. So we try to actively get in the distal tournament by with the Astator 30 grams steep wire, so which was successful. Can you see our image?
We see that, yes. Can you tell us exactly where you re-entered?
Yes.
Where do you think you re-entered the lumen?
We re-entered the distal lumen with the steep wire. Initially, I pulled back the gliding catheter and we changed the wire with the Astator steep wire, and then we tried to intraluminal approach into the distal cap. At that point, we actively tried to actively get in the distal lumen, which was successful.
So he's being very modest. I think we just need an RX because this is a 180 wire.
Any other comment from Moderator and panel?
So what is your plan now that you've achieved the true lumen with a guide wire? What's your treatment approach for the SFA?
We are small. We will try to perform ballooning with a small balloon, 3.0 by 120, and then the. Do you have TV? DrugEluting balloon. No.
So a couple of the issues here. Unfortunately, we started with first of all, congratulations to an expert technique in patience and persistence in using, I was actually advocating for, as John was, an outback, in which case we probably would have dilated the stent so we wouldn't have any problems over the 14 wire getting into the subintimal space. But I understand the expense associated with the outback. So a lot of patience and technique, getting it back into the true lumen. The issue now is that we have a 180 wire, and obviously without a 300, we're going to need an RX to get into the true lumen and find out where our reentry point is. We have a 4 French end-hole glide cath, and we cannot push it through the reentry point. So we're going to exchange that out for a balloon up the stent, and then we'll have the discussion. You know, John, we know the data from Dr. Nobuyoshi with regards to the grading of in-stent restenosis, and this would be a class 3, ISR. So if we just balloon this, we can expect restenosis within the stented segment in excess, or pretty much, we can pretty much count on it, actually.
The balloon is not available, the RX.
You have no RX?
Yeah, so we just have to go with this.
So what we're going to have to do here...
와이어.
Yeah, wire.
One second.
와이어가 지금 이게 와이어가 짧은 거야. 나왔어?
안 나왔어. Keep going.
Okay.
왜 안 나왔어?
Oh, yeah, I can see the tip of the wire. Okay.
자, 와이어 좀 당겨. Pull back the wire. Okay. 좀
So
당겨.
show us distal wire, please.
Thankfully, they were able to get the wire
Make sure we don't come back out of it.
without giving up the CTO.
Okay. Okay.
Where do you think you re-entered? That's the key, because we have to go into that point. This is a 10-centimeter balloon, so I would keep on pushing. There's nothing to be lost by dilating into the lumen. What we don't want to do is wing out this balloon and then try to push it forward.
Okay.
You want to try to put here? You think this is where you re-entered?
You don't want to go a little further down? Or?
I personally would, but that's your choice. So let's take a look. What we want to do is see a waist on this balloon to define our re-entry point. And that's the stenosis coming out of the distal stent. And I don't see the waist that we typically see when we re-enter the true lumen. So at this point in time, let me just see further up.
Okay. Good job.
Does that mean we have to go a little further down?
We have to go further down, but
Yeah.
the issue now becomes that we have a winged balloon that we're trying to push further. But clearly with excellent skills, we can do that.
자, 와이어 긴 거 주세요. 와이어 좀 긴. Long wire. We need a long wire. V18.
I push forward.
So their issue here is they're trying to make sure they cover the distal reentry point and treat that, not knowing exactly where they re-entered.
Where you re-entered. So what we're trying to do is find out where we re-entered, since it was not clear exactly. Show us up a little bit.
Okay.
So I don't see a waist on this either.
그럼 뺄게. 와이어 뺄게.
Okay, so we can pass the balloon a little bit further. Maybe we can pass the balloon what we believe to be in the true lumen.
So changing the wires now for a long wire.
Very good.
Commander wire.
So we may not have actually seen a waist. Okay. So we're still working with a 14 wire here, which now we decide what we're going to do here and what are our options. Balloon angioplasty, obviously, within the stented segment, within the native segment. Is it your practice that you would stent proximal and distal to that stent? Now, what do you do with total occlusion within a previously deployed stent? Do you do just angioplasty or stent?
I think that the occluded segment from the SFA os to stent distal portion. So after the angiogram, we judge to optimal stent length to cover the lesion portion.
There's just a lesion.
Yeah.
So what are you going to do within this occluded stent? Angioplasty alone, or are you going to do angioplasty plus a stent?
Angioplasty versus stent.
Okay. So you're going to stent the whole segment.
Yeah.
So
yeah, I want DB, but I think that DB is not available in your hospital. Available? Okay. 그러면 일단은 밸런 엔지오플라스티 위쪽에 밸런 안 더 해야 돼요. 예, 밸런 엔지오플라스티.
So
this is a drug-eluting balloon is available. So we previously thought that the drug-eluting balloon was not available. So we tried to do the angioplasty and then proceed with the stenting.
Yeah.
But now we know that we have the drug-eluting balloon. So drug-eluting balloon. So we can do the drug-eluting balloon for the intraluminal, in-stent, lesion, and then we can do stenting for the entry site. Is that the plan?
Well, if you change the calculus here for me, if you have a drug-eluting balloon, you're all the way up.
Okay.
Okay.
Hello.
So that now becomes a different story. If we have the option of a drug-coated balloon, that's great.
Okay, back.
I think we would need to pre-dilate the entire SFA first. So presumably the team will use a pre-dilatation. Looks like this balloon is very undersized.
So
Dr. Yu and Dr. Hong,
what is this?
What drug-coated balloon do we have for this case? Is it Medtronic or Lutronic?
Medtronic.
We have Impact 6.0 by 120 millimeter. Is this drug-eluting balloon? Yeah. We have several different lengths. We have the drug-eluting balloon in several different lengths. We have 5.0 by 120 and 6.0 by 120. So, which one do you?
Well, go ahead.
What kinds about the duty?
So it looks like this balloon is very small. So what size balloon do you have there now pre-dilating? Is that 3 millimeter?
6 by 120.
After I will perform the first the ballooning with more larger balloon. After that, we check the angiogram. Based on the angiogram, I will select the optimal the DB balloon size and length. Okay.
So the balloon that you're looking at right now is 3 by 120 millimeter.
Yes. So Dr. Laird was the national co-PI on the SFA impact trial, and the usual stent balloon drug-eluting balloon protocol is a pre-dilatation with a balloon diameter.
5.0짜리 긴 거 얼마짜리 있어요? 아니 그냥 긴 거.
What was the data outcome on impact for the CTOs?
5.0짜리 얼마 긴 거.
Have you separated out the CTO
So John,
data?
how would you proceed?
저 길이가 얼마 정도 될까?
We have not yet analyzed the
Length.
CTOs separately.
Okay.
So what was agreed upon? We're going to take a 6 by 120 distally and proximally throughout this whole stent and up in the native vessel?
Initially, I performed the balloon from the os to distal portion. After that, we check the angiogram, and based on the checked angiogram, we select DB or stent. DB, if we select DB, what size of DB and length, especially length. It's very important.
Yeah.
Okay.
Well, John, you would probably agree we're in uncharted territories with regards to the use of DEB in lesions this long with this technology in an adjudicated manner, where we have a sort of heterogeneous environment with native disease and then again with in-stent restenosis.
Wouldn't you want to stent this now? I mean, isn't that really the answer here rather than a drug? You can always do like a Viabond and then come back with drug-coated balloon later. I just wonder if this approach may be the right answer.
Okay. Well, I haven't seen an angiogram of the distal vessel yet, so I have no idea what we're treating down or seeing downstream. So that would be important to know.
오스 포션이 어디지? 좀 들어갔죠? 밑에 보여줘보세요. 밑에 더. 아직 안 왔어요? 이게 지금 프락시멀 포션이 아닌데?
Can you tell us what balloon this is?
Right now we are using the 5 by 200 millimeter balloon to dilate more. And then we're going to decide whether we're going to go with the drug-eluting balloon or whether we're going to stent the lesion.
오스 포션이 어디야? 저기 오스 포션 한번 좀 보여줘보세요. Could you show me the walls of SFA?
Yeah, we can go LAO to see where the ostium is.
Lateral view.
Yeah, LAO.
LAO.
So we want to see where the ostium is, make sure that we dilate that segment also. So
okay, 42.
Right, this goes right to the
42.3. Okay.
Right to the bottom of the acetabulum.
Okay. 자, 다시.
Okay. Back this way.
42.
So, Dr. Yu, we're going to switch back to the other room now to watch Dr. Heuser, and then we'll come back and join you. Could you just tell us what balloon this is?
A 5 by 200 millimeter balloon.
What balloon is this?
Armada 5 by 200 millimeter.
Okay.
Okay. Okay, we'll switch to the next room, if possible.
Okay.
Hey, John.
Hey, Rich, we're back with you now.
Yeah, John, we're still struggling over here. We got pretty far, almost to the distal end of the occlusion with the various wires. The Boston, the V wire, we went in with the stiff glide. We got pretty good position. Just couldn't cross it all the way, so we're just trying to get the Omni back up and doing the same thing because we were pretty close.
So, Rich, you're just working with the flush catheter again?
Yeah, I'm working with the Omni. And we got a Ansel for when we finally cross it. Tried a couple times to get up and over with the Omni, thinking the wire was
Have you thought about using a reentry catheter from below?
Yeah, that's an option. Which one would you use? Uh-oh, I lost my headphone. Which one would you use? I can't hear anything. Why don't you guys give me back? For me? That's pretty good there, huh?
Pretty good, yeah. How about check this one?
You're going to shoot from there? Yeah, we'll shoot from the... see how far we're in.
네. 알아요. 근데 이거 소리가 안 들렸어요. 그래 이제 들려요.
Yeah.
오케이. 따졌어 거기까지. 자, 체크해볼게. 앞서 기다리고 있어요?
Yeah, see what you want to put on Cine here?
Yeah, Cine.
Okay, we're pretty close.
Yeah.
It looks like you're very, very close here.
Yeah. I agree.
So it looks like subintimal probably, but an opportunity to pop back into the true lumen right there.
Yeah. The problem I have is I don't...
Obviously having some audio issues here.
Yeah.
With with the other room.
Yeah.
It's great to hear Dr. Bookbinder so clearly.
Yeah, I really hear him very well.
Interested in the case.
Yeah. He's got a distinctive loud voice.
Which wire are you working with right now, Rich?
I got a stiff glide wire, 035 stiff glide.
Also nice to hear Dr. Mintz so clearly.
Yeah, I heard him very well there.
Eventually they'll get the right channel.
Yeah. Ooh.
So this is the challenge from the contralateral approach, is inadequate backup support to advance.
Yeah, what do you think? What do you guys think about?
That's why I like Simmons catheter because it sits in there a little bit better.
What do you think about taking this
this sauce curves?
Maybe the sauce out or a flexible 035.
Yeah, okay.
You want to try a 035? What do you got for me? What choices do you have for me?
But
oh,
just
that.
need
Okay,
a little
good.
bit more backup support here. And then of course, if you came
I think
from
I'm
the
stuck.
arm,
I think I'm stuck.
You would
so
be able
hopefully
to
it won't
stuff a
come out.
multi-purpose type curve right into the stump and have
Whoa, whoa,
very
whoa.
good backup support to try and
You're going to do it?
cross.
Okay. Whoa. Don't pull that wire back at all. Okay.
I
I'm here.
usually just form it in the arch. You know, I know that's blasphemy to some people, but it's a very simple procedure. It just takes 30 seconds.
So we're taking the Omni out.
So Dr.
gingerly.
Heuser is now leaving the wire in place and trying to bring a catheter around the horn, which will sometimes work, like a quick cross or support catheter of some kind.
Cross 018 usually works.
Yep.
Rich, tell us again what wire you're using here. We're finally
stiff 035
enough that we can
glide
hear you,
wire.
because we had a lot of noise from the other.
I don't know. I really like all that noise. It's a lot more beneficial on this end.
Now I think he's off.
035? No,
so
I'm.
let's go to the other room to see the final.
Okay, good.
Final decision on in room 2.
Good.
With Drs. Singh and Yu and Hong.
That's great. I think we're stuck in the plaque, which is good. I like that. Okay, you're going to have to give me a little negative probably on that wire.
Well,
That's
I've
good.
now been informed, I guess, that we have some technical issues with the satellite,
good.
and we're not going to be able to go back to the other room. So we've been challenged by the cases. We've been challenged by the technologies.
Oh, no.
We've had audio problems. We've had case problems. So this is real world. I think we see sometimes that not everything
Let's
goes
do this.
perfect in a live case.
I think we go back with the Omni.
So any last comments from the panel here, thoughts about Lawrence? What would you do next here with this case?
If I was hell-bent on coming from above, I would flip over to a brachial approach and just use a multi-purpose. If I thought that we could, do the finger of God and connect the two dots, the retrograde technique I think is reasonable, and it's probably a shorter distance, so I don't have a problem with that approach. But I think I'd bail on the contralateral approach at this point.
Yeah, I think it's either get a better support catheter or just do a retrograde with a reentry catheter for me. Okay, well, I think we'll close this interesting and challenging session. Thank you very much for your attention.